Welcome to this American Heart Association video on demand session entitled The Role of Modern Algorithms in Cardiovascular Risk and Risk Assessment. I'm Don Lloyd-Jones. I'm a cardiovascular epidemiologist and a practicing cardiologist at Boston University in Boston. And joining me is Dr. Sadia Khan. Sadia?
Hi, everyone. My name is Sadia Khan. I'm a preventive cardiologist and epidemiologist at Northwestern University Feinberg School of Medicine. Glad to join you today, Don.
So today we'll explore the key elements of algorithm performance and the factors that make an algorithm an effective clinical tool. We're also going to examine the data and the assumptions that are present in some of our most familiar clinical risk assessment tools and introduce you to some of the newest risk assessment tools. Now, this work was supported by grant number 2023-0150 from the Doris Duke Foundation, but it's important to note that recommendations and opinions that are presented may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by AHA. The AHA does not endorse any product or device. So moving ahead, these are our disclosures for both Dr. Khan and myself. And then I think we're ready to get started. So I'm going to kick it off, I think, with our initial segment to talk a little bit about why we have risk assessment tools and clinical decision tools in the first place. How do they help us clinically? So for risk scores and clinical decision rules, we use these broadly in clinical medicine. We use them for diagnosis, for prognosis, and for treatment decisions. And it's clear that we need them because signs and symptoms for diseases are rarely pathognomonic. Just because you have a symptom doesn't mean you're going to have that disease. Shortness of breath is a classic example, could be due to many, many different things. Likewise, on the other end, risk factors are almost never deterministic for disease, right? We know that if you have high cholesterol, you may or may not develop heart disease. So it's important to kind of work that into how we're assessing the patient. Often we need these sort of prior probabilities. What's the pre-test likelihood that the patient has the disease of interest? And so we're left with these conundrums. Should we test everyone? Should we treat everyone? Should we treat nobody? Or in fact, can we do this a little bit more intelligently and pick those people who are most likely to benefit from this? Often we want to enrich the pool where we can treat people most cost effectively. And we find that patients and clinicians are actually really poor at making these decisions absent some assisting device. And that's where clinical decision tools come into play. Next slide. So why do we estimate risk? Well, certainly for people like me, there's clinical and academic interest. We want to understand underlying mechanisms of disease or identify novel risk factors or targets for therapy. But also we want to understand the relative contributions of different risk factors in the incidence of disease and understand those comparative risks. If you have a given risk factor like hypertension, are you more likely to develop a stroke first or heart failure first, or perhaps a heart attack first? That may help us understand how aggressive and in which risk factors we want to intervene first. And finally, it helps us compare the risks of disease with the potential benefits and the harms of the therapies, particularly the drug therapies that we're likely to use. So we want to target those drug therapies to the people who are going to benefit most and try to minimize the number of people who are going to have side effects from those therapies. So why do we estimate absolute risk? Well, we estimate absolute risk because relative risk is a pretty poor way to communicate about the benefits of therapy. And the problem here is that who am I comparing this patient to? And it's often not clear, right? So if I tell a patient that they have a 10-fold higher risk for a certain disease and the risk in the reference group is 0, well, I'm not really imparting much important information to that patient, even though it might sound scary. It's really helpful for that patient and the clinician in particular to understand the absolute risk that this person will develop some disease in the next unit time. Because again, the higher that risk, the more likely I am as a clinician to want to intervene. So it does help us improve communication and motivate adherence to the recommendations we make to the patient. But most importantly, as we're making these decisions, again, we want to make them as intelligently as possible to target those therapies to the people who are most likely to benefit and least likely to actually suffer consequences like adverse effects from medications. Okay, So how do we do this? How does this sort of play out on a mathematical framework? Well, if we think of this blue arrow, the x-axis, as the absolute risk that someone's going to have an event, like a heart attack or a stroke, the information that we get from clinical trials tell us where there's a threshold of net treatment benefit. That is, we're more likely to prevent a heart attack or stroke than we are to cause an adverse side effect from a medication. Here, though, from clinical trial data, we may know that the risk of an adverse event, let's say developing diabetes if one is started on a statin medication, is also at a known and certain level. And usually that's a pretty low level because it's a safe approved medication. So for the patient sitting in front of me, what I want to do is I want to choose someone who's in that net benefit zone, right, where I'm more likely to prevent a heart attack or stroke than cause an adverse event. But if I choose someone down at the low end here in the net harm zone, I'm actually more likely to get the side effect than I am to prevent the heart attack or stroke. So this kind of helps me gauge where my patient is sitting in this spectrum of risk and benefit so that I'm actually making and targeting the decisions that will help the patient the most in their certain situation. But the question then comes, where does my patient fall? Where does this person sitting in front of me fall in this spectrum? And the answer to those questions is, this is why we need clinical risk prediction algorithms. So I can say, this patient has a high enough risk that they're going to fall into the net benefit zone if I start a therapy, because I know I've predicted what their 5-year or 10-year risk for disease is. So I'm going to give you a couple examples of how this plays out. And, I think these should be pretty familiar clinical decision tools that are based on risk estimation equations to try to understand, again, where net benefit lies for a given patient. So this is the example of how we decide to use anticoagulation in patients who have atrial fibrillation and therefore at risk for stroke. So when we think about anticoagulation in atrial fibrillation, the clinical tool, the risk estimator that we use is the CHADS-2 VASC score. And most clinicians, I think, are quite familiar with this. It's a 9-point scoring system. And you see on this slide the different things and the point scores that are assigned to them. And you simply add up the points for any of these conditions that are present for the patient sitting in front of you. Okay, so that's the score. How do we turn that into clinical knowledge or decision making? Well, we have data from a number of large-scale studies that tell us that based on your CHADS-2 VASC score, we can predict what the stroke event rate is per year. And you see here that with increasing CHADS-2 VASC score numbers, you get a higher percent of stroke rate per year across the spectrum of CHADS-2 VASC point scores. Okay, so that's one piece of information, but without the second piece of information, you wouldn't quite know where to put the threshold. You might say, well, gosh, 5% per year seems high enough that I would put someone on an anticoagulant. Great. But we actually know other information from those clinical trials, that is, the risk of a major bleeding event on anticoagulants is about 1 to 2% per year. Okay, so now we know where our net benefit zone is likely to be compared to our net harm zone, right? And sure enough, if you put these two pieces of information together, it looks like around 2% per year is our break-even point. And that may be where we want to put our decision threshold to say anybody above that threshold probably ought to be treated because we're more likely to prevent a stroke than to cause a major bleed. Anywhere below that threshold should be a conversation, most likely. And in fact, that's what the current atrial fibrillation guidelines recommend for the prevention of stroke. That is to say, as you see here in the top box, a 1BR recommendation that if a patient has a 10-year risk estimate from CHADS-2 VASC, if they have a per year risk estimate from CHADS-2 VASC of 2% or greater, then they are recommended with a class 1 recommendation that they should take anticoagulant therapy. Okay. Here's another example, and this is hot off the presses just from the most recent 2025 AHA-ACC high blood pressure management guideline. And in this guideline, we actually deployed a risk-based assessment and treatment approach to minimize the bad outcomes that can be associated with hypertension. And here's a graphic from those guidelines and an associated paper that Dr. Khan was the first author of, where you can see we take this stepwise approach so that we're choosing patients at higher risk to try to maximize the benefit and, again, minimize the exposure to potential side effects for patients who don't need it. So at the top of this graphic, you see if the patient has stage 2 hypertension, that is an average blood pressure greater than 140/90, we would treat all those people. They are at high enough risk, and we know there's benefit in that group. Dropping down now, if there's stage 1 hypertension, that is a systolic blood pressure of 130/139 or a diastolic blood pressure of 80/89. If those patients have pre-existing clinical cardiovascular disease, we treat them. They are at high enough risk in addition to this stage 1 blood pressure level. Dropping down to the next box below that, if they have something like chronic kidney disease or diabetes, likewise, we would say they're at high enough risk, they're going to benefit from therapy, the benefit outweighs the harm, we treat those individuals. If they don't have any of those chronic conditions, but they have a predicted 10-year risk over 7.5% using the PREVENT risk estimation algorithm, which you're going to hear about, then again, they're in a benefit zone because we know from clinical trials that patients at that degree of risk or higher are more likely to get benefit than have any harm. And then finally, there's this sort of catch-all bucket. Patients with stage 1 hypertension, but at low predicted risk for a cardiovascular event in the next 10 years, that is less than 7.5% by the PREVENT CVD equations. Those people are at low enough risk in the short term that we can use 3 to 6 months of attempted lifestyle intervention to try to get their blood pressure to the optimal goal of less than 130/80. If they're unsuccessful in achieving that, then there's a conversation that happens between the clinician and the patient to say, well, we're not successful at that. We know your blood pressure is only likely to go up over time. We should probably start therapy today in order to reduce your overall lifetime exposure to elevated blood pressure and prevent the development of higher degrees of hypertension. So you can see this sort of stepwise approach that, again, is maximizing the benefit based on the risk level of the patient because they have chronic conditions or they have a higher predicted risk. Okay, so that's the end of section 1. And Sadia, let me bring you in here and see if you have any comments over and above what we just talked about before we introduce the PREVENT risk equations, which are used by the hypertension guidelines as important ways to improve decision-making in medical therapy.
Well, thanks, Don, for that overview. It gave us a great perspective, really, of the full spectrum, right? We started with the example of atrial fibrillation, where somebody already has pre-existing cardiovascular disease, and how do we identify and prevent their risk for stroke? To the other end of the extreme, in patients with high blood pressure, how do we prevent that first event of cardiovascular disease from occurring? Now, this is also the approach that we use in other risk factor management, like cholesterol, and maybe perhaps the best studied. And when we think about cholesterol or hypertension, you mentioned the 7.5% threshold. I guess I wondered, do you want to talk a little bit about how did 7.5% come to be for the blood pressure guidelines, and why is that an important threshold?
Yeah, it's a great question. Sadia, I think, as we introduce the PREVENT equations in this next section, maybe this is a good background for people to understand. When you introduce a new risk score, it allows you the opportunity to think about what is the optimal decision threshold in the setting of this new risk score. And so as we looked at this carefully in the hypertension guidelines to try to find where that optimal decision threshold should be, we considered a number of different parameters. And, of course, the first of those is how do risk estimates that come from the PREVENT equations line up with our prior platforms for risk estimation, most notably the pooled cohort equations that have been endorsed since 2013. And what we found there was that, in general, the PREVENT total cardiovascular event predicted numbers are about 40 to 50% lower than those provided by the older pooled cohort equations. There are a lot of reasons for that. But in general, it's because PREVENT is from a much more contemporary population of patients that reflects the patients, again, that you and I are seeing, but also really reflects the lower event rates generally in the population because we have made some progress in preventing this disease on the population health level. But we also thought about what have been the entry criteria and what have been the characteristics of people in these important hypertension treatment trials, like the SPRINT trial that everybody knows about. And in fact, the SPRINT trial enrolled people with a 10-year predicted risk of 15% or higher using an old risk platform, which corresponds quite nicely with a prevent CVD risk estimate of about 7.5%. So that's also something kind of pushing us toward that decision threshold. And finally, when we looked at how many people in the population are currently recommended for therapy under the current guidelines, and then with these new guidelines and a new decision threshold, we don't want that to alter too much. We certainly don't want to be removing people from recommended therapy. And so it turned out that 7.5% aligned very nicely with existing recommendations and, of course, with the evidence base. And so that's some of the thinking that goes into when you have a new risk equation, how you can reset the decision threshold to make sure it's aligned with all the goals that we have.
Yeah, that's really helpful. And I think it just reminds me when we're talking about these risk scores, one of the most important pieces, both for clinicians who are using them and for the patients who are hearing about them, is what do I do with this information? And so that's the kind of marrying the model or the equation with the threshold to really improve health.
Exactly. So Sadia, why don't you take us through the development of these new prevent risk equations, which you were really central in driving that effort for the American Heart Association. I think people will really be interested in learning just how you develop a new risk equation and the care and thought that went into that.
Awesome. Thanks, Don. Well, let's do a little bit of a deep dive. You heard a little bit about how the prevent equations have now been endorsed in the high blood pressure guidelines, but where did they come from and what did we use to develop them? So the first question that we asked ourselves as we were setting about to develop the prevent equations were, what were the data sources that were available to us and would allow us to have a broad, diverse, and contemporary sample? You heard from Don that making sure that the sample represented the patients that we were seeing today in clinic was going to be really important. And so we broke it up into two categories. We accessed data from research cohorts. So these were participants that had enrolled in community-based studies such as the Cardiovascular Health Study, the Multi-Ethnic Study of Atherosclerosis, the Atherosclerosis Risk in Community Study, the Framingham Heart Study, the Jackson Heart Study, and the Coronary Artery Risk Development in Young Adults Study. That's a mouthful, but really represents that we were able to utilize all of the available research cohorts that had objectively measured predictors and, importantly, adjudicated outcomes. But we also wanted to support, but we also wanted to add a diverse contemporary sample from everyday life in clinical practice. And electronic medical record data allowed us to really capture the broad spread of patients in the US receiving care. We accessed Geisinger and Optum to have a total of 3 million individuals in the development and more than 3 million in the validation sample to really ensure that we had this large, contemporary, and diverse sample to start with. In terms of the racial and ethnic diversity in the development of the prevent equations, you see this figure here that shows 3 bar graphs for each race and ethnic group: non-Hispanic white, non-Hispanic black, Hispanic, non-Hispanic Asian, and other race and ethnicity. And these are divided based on the census data for the years during which prevent was developed in the green, more contemporary data in the red, and then in the blue are the distribution from the development data sets for prevent. And you can see for the first time, Hispanic and non-Hispanic Asian individuals were included in risk prediction assessment or risk prediction equation development, and that the sample was broadly diverse. Now, this is really important when we start to think about how well does the model perform in other samples? How well does it perform in your patient population today? Well, if your patients aren't represented in the development of the equation, it's not going to do as well. And so this was really important as we were thinking about development. So what's new about the prevent equations? This is a really nice infographic that sets up how we thought about what were the equations that we needed to use to be able to provide both a base assessment, that's the inner circle, traditional risk factors that are routinely available, so all the things you think about: age, blood pressure, cholesterol. Importantly, kidney function was a new predictor that was included in these base equations: cholesterol, diabetes status, and statin medication, as well as antihypertensive medication status. In the outer circles are add-on models. So you have the option to add UACR for kidney function or urine albumin creatinine ratio, hemoglobin A1C when it's measured for either screening or diagnosis and management purposes with diabetes, or a zip code-based social deprivation index. And the important reason for adding that was to really start to account for place-based risk related to cardiovascular disease. We set it up in this way so that the base model would be able to be calculated routinely in any clinical practice, and when available or indicated, the optional predictors could be added to refine risk. In the table here, we go through all of the new parts of the prevent equations and highlight some of the key considerations, including the ability now to extend risk for 10-year and 30-year, so that longer time horizon, which is especially going to be important in younger adults, the optional predictors that allow us to really refine risk, particularly for patients who have diabetes or chronic kidney disease, and are among the highest risk patients that we see for cardiovascular disease. All of these changes together led to a more accurate model. So let's take a look at how the model did. These are calibration curves. You see on the x-axis is the predicted risk, and on the y-axis is the observed risk, and each line represents a data set. And you can see in the validation sample, both for males and females in the two panels, all of these lines hover around that perfect slope of 1, where the predicted risk matches the observed risk almost perfectly. So across a broad set of research cohorts as well as EMR data sets, we see near perfect alignment of the predicted and observed risk. And I think the other thing that's really important or helpful about this is that this also represents patients across the United States. So we have broad geographic diversity in the participants that were included. The other key question that comes up, you'll notice when I went through the predictors, I didn't mention race and ethnicity. Race and ethnicity as a social construct was not included as a predictor, but we know there are real differences in terms of race-based differences in cardiovascular disease risk. Within the United States, African Americans have a more than twofold higher risk of developing cardiovascular disease and dying from cardiovascular disease. So we wanted to make sure that we were not underestimating risk in certain populations. You see here the calibration estimates for Asian adults, Black adults, Hispanic adults, and white adults, and both for Prevent CVD and Prevent ASCVD, the two outcomes being total cardiovascular disease, including atherosclerotic cardiovascular disease, as well as atherosclerotic cardiovascular disease by itself. All of these calibration slopes are near 1. So again, we're matching our predicted with our observed event rates. Now, when we compare this to the pooled cohort equations in the same sample, this is exactly what Don alluded to. We see a slope of about 0.4 to 0.5 for all of the race and ethnic groups, which suggests that the estimate with the pooled cohort equations is overestimating risk by about twofold. And for each race and ethnic group, the prevent equations provide a better estimate that's better calibrated. Since the publication of the prevent equations, there have been a multitude of papers that have been published looking at the prevent equations in different health systems and data sets. This one is from Northern California that shows disaggregated racial and ethnic groups, and each bar represents the observed and predicted risk across race and ethnic groups. And you can see they line up. The heights are very close to each other, while there's some variation, which is a really nice finding when you start to identify, even within large racial and ethnic groups like Hispanic individuals and Asian individuals, we know there's distribution as well as differences in cardiovascular disease risk. And what we're seeing is that based on the predictors included in the prevent equations, the predictors themselves have differences across race and ethnic groups: hypertension, diabetes, chronic kidney disease. Accounting for the differences based on the predictors and biological or clinical factors that are going into the model allows us to still capture race and ethnic differences. So I want to pause there and ask Don, based on that overview, What kinds of questions do you think are important as we think about implementing and interpreting these risk equations now?
Yeah, I think it's really important. And what a wonderful overview, Sadia. Thanks for that. And, I know that that was a huge amount of work. Imagine harmonizing the data across what ended up being more than 6 million, almost 6.5 million patients, so that we could really enhance the confidence in, what the output is from this model. And, I want to focus on that first. I think when we introduce any new clinical tool, it's very important that we get the buy-in of the clinicians, because if we want them to implement it, they need to be confident in the results that they're seeing. So, thinking about the development and the validation of those, what is it about having more patients that can enhance our confidence that we're going to get an appropriate risk estimate for the patient sitting in front of us today?
Yeah, that's a great question. And it goes back to some of what you described in the first section. Risk estimation itself is probabilistic. So we're trying to come up with the best estimate that we can, but for individual person and in that clinician-patient discussion, what we're trying to then convey is how likely is it that you, compared to perhaps 99 of your peers that are the same age, sex, have the same risk factor distribution, would have an event in the next 10 years for the 10-year risk estimates. And I think one of the pieces to your question is that the larger the sample, the more generalizable and inclusive and contemporary the sample is, the closer we can be in terms of precision, because we're really capturing the average person as well as we can, knowing, and as we think about risk enhancing factors and personalizing risk communication, that we're not going to be perfect. And risk estimation isn't meant to be perfect, but a starting point.
Yeah, I think that's really well said, Sadi. And, I think about two aspects of this, right? There's the accuracy and there's a precision. So thinking about the upgrade that Prevent provides over and above what we had from the pooled cohort equations, I think the accuracy lift that Prevent provides really probably comes from the fact that it's much more contemporary. It's looking at populations and people who were born in the range of the patients we're seeing today, not patients who were born in much, much older birth cohorts that frankly, whom many of them are not alive today. So it's not as relevant a thing. So that gives us, I think, much enhanced accuracy when we're using the Prevent equations. But your point about the numbers, that's, I think, what really locks in the precision. If you think about the pooled cohort equations, those were developed in about 25 to 30,000 individuals, not 6.5 million. And there were about 5,000 events. Well, there were more events in the cohorts that were developing the Prevent equations than there were actual people in the pooled cohort equation development cohort. So that just substantially, I think, narrows the uncertainty around any given risk estimate because it's just based on so many more cardiovascular events. And it can really tell us that, if we estimate a 10-year risk of, let's say, 7.5%, then that patient really is in a group that's in a pretty narrow window around that risk estimate. Now, there are individual considerations that might move us higher or lower than that initial risk estimate. But I think, clinicians really can have more confidence using the Prevent equations because they are more contemporary, therefore more accurate, and they're developed from far, far more people, and therefore they're more precise. I don't know, what would you say that some of the other, you showed one paper that's been published since then, but as you said, there've been a number. And so maybe you could summarize what the sort of full range of papers that have evaluated the Prevent equations and what we've seen from those.
Yeah, and maybe even before that, one of the things that I think have been a great resource has been with the American Heart Association Prevent Online Calculator. There's access to source code. So for others who are interested in evaluating the Prevent equations in their data set, I think this has been a real boon to allow this rapid external validation occur since the publication of the Prevent equations. We've seen far more papers, far more patients, far more validation for the Prevent equations in a very short period of time than we had to date, even for the pooled cohort equations over a 10-year period. And I think that's in part because we have broader and bigger data sets and available access to code has supported that as well. So as we start to look at the available literature in the past 2 years since the publication of the Prevent equations, we see that largely the discrimination, or as you say, the accuracy that is seen across data sets is broadly in the good to excellent range. almost all of the samples in the publications, we see very good C statistic numbers, which are essentially telling us how well are the equations rank ordering people. Where we see some variation are these calibration estimates, and the slopes are around 1 for most of the data sets where this has been evaluated, including in the VA, in the Veterans Administration, which is another national large data source of more than 2 million patients that were included in that report with really high risk features. We saw very high event rates in that sample, but Prevent had very good calibration there. There are some individual health systems where there has been underestimation with the Prevent equations, and there's a variety of reasons that that might be the case. We know that if the sample is at higher risk systematically, if there are differences in coding or differences in event rates, this is where we get into the nuances of what defines a cardiovascular event. And actually, a really important question as we start to think about prevention, if you identify subclinical atherosclerosis on an incidental finding on a CT, we should be treating that person as if they have ASCVD. And it's not really a question about risk estimation, but how do we prevent progression? And so I think the more we think about what even defines a cardiovascular event and we start to push the needle back, I think we're going to have better outcomes from a prevention standpoint.
Yeah, great exposition on that. I really like the way you said that. And something that you highlighted that I think I'll just double down on is that, there is open source code available so that you can program these equations into your local electronic health record and have it auto calculate for you. And we certainly anticipate that a number of the big vendors will be incorporating this in as they update their instances of their electronic medical record platform. I think we'll start to see, just as we saw the pooled cohort equations adopted, we'll see the Prevent equations adopted, particularly now that they're part of the hypertension guidelines, and really can be worked into the workflow of clinical decision making. So maybe I'll take us forward then to the next section, if that's okay with you, and talk a little bit about how we interpret some of these updated clinical algorithms. So I think one of the key points, and Sadi, you touched on this, that race was not included in the new Prevent equations. And in part, as you said, that's because race is not really a biological construct. It is a social construct. And we have some knowledge that, in fact, when we've included race in prior clinical decision algorithms or risk estimating equations, in fact, it may have harmed people. And this was, I think, a really seminal paper that was published in the New England Journal of Medicine back in 2020, focusing on a number of those clinical algorithms that are available, but really, I think, focusing in on one in particular, which was the CKD epi equations for calculating the estimated glomerular filtration rate from most often from creatinine levels, right? Using certain clinical parameters to translate a creatinine into actual kidney function in terms of an eGFR. And this article, I think, really called into question whether that was appropriate, because the way the old eGFR equations calculated the eGFR was different based on the race of the individual. And that tended to lead to, in some cases, some substantial overestimation of the true eGFR in Black patients. And therefore, we were potentially missing the diagnosis of chronic kidney disease in a larger number of Black patients than in other groups. So obviously, that's not a great outcome. There were a couple of other clinical equations that were cited in this article, but this was, I think, the one that really grabbed people's attention and made us question why race might be included in these algorithms and whether it's appropriate or not, right? Now, we know that there are some valid arguments about whether there could be some genetic underpinnings in certain situations for people from different genetic heritages, but in the main, this is a social construct. It is not a biological construct, and we may be just perpetuating biases about treatment that disadvantage those populations if we include race as a feature of some of these algorithms. And so in response to that, and very quickly after that paper I just cited, the New England Journal, there was another publication where the group that had developed the CKD epi equations updated their equations, removed race, and actually used variables and weighted them in different ways to make sure that they were actually creating a better EGFR estimation equation. And you see here the conclusions from that paper, that these new 2021 CKD-EPI EGFR equations that omit race are more accurate and led to smaller differences between Black participants and non-Black participants, and therefore, again, more appropriate clinical classification. So I think, just as that happened for CKD-EPI, well, the pooled cohort equations did not underestimate risk and therefore withhold therapy potentially from Black people, with statin therapy from Black people that could help prevent cardiovascular events. In some cases, we saw that the pooled cohort equations might actually be overestimating risk a little bit in Black compared with white participants. If you've got a safe therapy, that may not be a problem, but we'd like to get this more accurate for everybody. And so I think this is a real upgrade that the PREVENT equations also provide us as well. So, again, I think I kind of alluded to this, to what you see here on this slide. When the pooled cohort equations were developed back in 2013, we had enough data from white and Black Americans from the cohorts that were included to create separate equations for white and Black Americans. But we didn't have data, unlike for PREVENT, we didn't have data back then on disaggregated Asian populations or even aggregated Asian populations, and certainly not for people who identify as Hispanic American or South Asian. And so we made based on observational data, we made broad recommendations saying that if you use the white equations for someone with East Asian or Hispanic American heritage, we should know that we're tending to overestimate the risk if we're using the white equations. And likewise, if the patient is a South Asian American, we are tending to underestimate their risk if we use the white equations. So we kind of had this qualitative fudge factor, if you will, for those race and ethnic groups, which wasn't ideal, and I think led to some confusion as well. So all of this is to say, race and ethnicity are still important, right? What race and ethnicity represent in this time in our country provides important context about the lived experience of that individual, right? And the potential social drivers of their health. But anymore, and especially with PREVENT, as PREVENT was developed, it turned out that the variable that was representing race was not statistically significant when we had the other variables in the equation. And so, we didn't need race anymore, essentially, to capture some of that risk. It's captured by the risk factor levels that differ, sometimes by race and ethnicity, and captured by the weighting of those variables in the equations. And so, we can do without it, if you will, in cardiovascular risk estimation anymore. So let me stop there, and before we move on to the next session, Sadia, I know, again, you were deeply involved in some of the development and understand the nuances of when race was included or not included. You very nicely showed the data that, the calibration and the performance of the PREVENT models in different race ethnic groups is essentially similar. And so we didn't lose anything by excluding race as a variable in the model. But how do we think about it clinically? If you have a patient from a typically underrepresented group that's not, as represented in some of these equations, or that has a lived experience that potentially could put them at higher risk, how do you work that into your clinical decision making?
Yeah, thanks, Don. I think that's a great question in terms of what are we really trying to accomplish by using race and ethnicity in our models? It's a shortcut, right? It's a variable that we can start to consider and include. And I think one of the challenges that has really come to light is that there's the potential for harm when we use a shortcut like this, that perhaps there may be a misinterpretation that race and ethnicity is biological in and of itself. And I think that's a really important place to start from and then consider, so what is it representing? I think you asked this really nicely to say, what do we do with the patient in front of us? So I think there's two parts to that. There's the social part and then the genetic or ancestry part that we're trying to really tease apart. And we're at the point now where I think we can do that better and directly measure the things that we need to incorporate to assess risk more precisely than use a surrogate like race and ethnicity. So I also think we have had such successful advances in terms of our ability to evaluate genetic variants. So specifically for FH, for example, or lipoprotein little a, or are there family history considerations? So one of the things that I do in clinical encounters is a 3-generation pedigree, and really get a better understanding of what is the family history in that person's family and how may that influence or incorporate into their risk decision counseling. Now, on the lived experience side, I think the advances from a I think the advances from how we're approaching assessment of social determinants of health has really been helpful. I know in our clinic, within our electronic medical record, we now have places to actually incorporate specific risk factors such as housing instability, transportation challenges, food insecurity that really get at are there specific challenges currently that may influence cardiovascular disease risk, both from an ability to access care, have continuity of care, access medication, and have adherence, as well as overall risk and we're trying to get at? So I think those things and the ability to now more directly measure the factors that we were trying to substitute with race and ethnicity are really important, but also the fact that race and ethnicity have the potential for harm by being included and being conflated with ancestry or biological factors were really the driving factors in how we thought about this.
Yeah, Sadi, that's so beautifully said. And you brought up one example where the direct measurement is so much more important than the old perceptions about, racial differences and the implications. And that's lipoprotein little a, which is everywhere these days, right? We're really acknowledging now that this is almost certainly a causal risk factor for cardiovascular disease, especially atherosclerotic cardiovascular disease. We may be on the threshold of having some direct therapies for elevated lipoprotein little a. We'll see. But the old buzz was, well, we know that LP little a levels are higher in people who identify as African American or people who identify as South Asian, but the risk isn't the same. And we know now with more data, which is often the solution, that's just wrong. That whatever your level of LP little a is, the risk that's associated with that is identical, regardless of what group you identify with. And so, I think we really are moving beyond this need to identify people because we can now develop, we can actually now directly measure the biology and the risk factors that are putting those people at risk. But the context, as you point out so nicely, is still critically important because so much that happens upstream in terms of their, what develops their risk, and so much of what happens downstream, their ability to, eat a healthy diet, perform physical activity, go out for a walk in a safe environment, and adhere to the recommendations that we provide them. So much of that is determined by those social drivers. And so it's critically important that we never forget about that context, but we don't need these in our mathematical equations anymore. So beautifully said. Maybe you can bring us home in this last section of the video on demand and talk about how people can implement PREVENT in clinical practice.
Yeah, thanks, Don. We wanted to share a couple of cases so that we could try to highlight how the PREVENT equations may be used, specifically related to high blood pressure management. So this is our first case here. So this is a 60-year-old man who presents for an initial visit to consider antihypertensive therapy due to an elevated blood pressure reading that was obtained at a community fair. A friend recently developed heart failure, and he is also concerned about his risk. You see the blood pressure reading there, 132/80 in stage 1 hypertension, BMI in the obesity range at 32, and an exam that's overall unremarkable. In terms of lab values, the total cholesterol is 220, HDL cholesterol is 50, and kidney function is a little impaired with an eGFR of 55.
The
Yes,
EGFR uses the new equations, yes.
and the eGFR uses the new equations and estimates an impaired kidney function. If we implement risk assessment as the first step and plug these numbers into the PREVENT equations, we get an estimated 10-year risk of 12%. So what do we do with that information? We talked about this a little bit in the first segment when we were talking about the flow diagram for how we approach risk in hypertension management. Well, this person has stage 1 hypertension. They don't have diabetes. They do have CKD, and their estimated risk is 12%. When we think about the clinician-patient discussion, we want to talk through the risk that we have calculated, review any risk-enhancing factors that may need to be considered to contextualize the risk estimate, and talk through a clinician-patient discussion of what are the benefits and potential side effects of antihypertensive therapy. But I think it's clear to all of us that there's sufficient risk, and our recommendation would be to initiate antihypertensive therapy today to lower risk for cardiovascular disease in this patient. There's a couple of things that really we want to highlight for this scenario, and that will contrast with the second clinical scenario. This is a patient who has a second high blood pressure reading in the clinic. They have risk factors with obesity and impaired kidney function. And we know that initiating blood pressure therapy with a target of less than 130/80, although even approaching less than 120, is going to reduce the risk for cardiovascular disease in the next 10 years. Now let's take a look at the second case where we have the same blood pressure reading, but some differences. This is a 35-year-old woman who came in to discuss antihypertensive therapy, also due to an elevated blood pressure. We see the same blood pressure reading, the same BMI, and a similarly unremarkable exam. When we take a look at the lab values here, the total cholesterol is 160, HDL cholesterol is 60, and kidney function is normal with an eGFR of 110. When we go ahead and plug in risk assessment as the first step for this patient, we have stage 1 hypertension in a young patient, and the absolute risk for 10 years risk of CVD is 0.5%. So when we compare that to the first patient, there's several factors that are contributing to this, but it really sets up a different conversation and discussion. As we go through those same steps in terms of the risk of CVD, reviewing risk enhancing factors, and talking about what may be benefits of therapy, the benefits are going to be lower here because the absolute risk is lower. And so the discussion leads to a recommendation for initiating lifestyle changes, but importantly, reassessing blood pressure again after 3 to 6 months. Because if the blood pressure remains elevated, we want to make sure that we consider this as a means to then consider antihypertensive therapy at that time. Even though the absolute risk is low, we know that the risk of blood pressure accumulates over the life course, and so we don't want high blood pressure to go unchecked for a long period of time. As we think about these two cases, I'm going to ask Don, what do you think are the two things, or are some of the things that may strike you as differences as you have these conversations for the same blood pressure reading with these two patients?
Yeah, I think they're really nice illustrative cases because, again, so many of the clinical parameters are the same. Yes, the cholesterol differs, but what's the big difference between these two people? It's their age, as you pointed out, right? And so age is such a strong driver of risk. And some people complain about that, but that's a fact of life. I have more gray hair than you do, Sadia. Of course, my risk is higher, right? And in fact, that's truth. And so, I think that's a clear driver here. But it's very important then, that we contextualize that risk and we respond to it, right? And the gentleman with the 12% 10-year risk estimate already has CKD. We know that leaving him in this blood pressure range is only going to cause further harm, further target organ damage, and allow risk for stroke, heart failure, ASCVD to be unchecked. He needs immediate therapy, right? And I think the risk estimate really focuses us on that quite nicely. The young woman in scenario 2, again, same blood pressure level, but we've got time. One of the nice features of PREVENT, as you pointed out, is, with the pooled code equations, we could only start to estimate risk at age 40 and above. Here, we can start to estimate risk using PREVENT at age 30 and above. And she was 35 years old. And so we can get this 10-year risk estimate. We can say, okay, we've got a little bit of time to actually see if lifestyle can help us lower her blood pressure to her goal of less than 130/80. And, try to really get her to adhere to some of these things that will be of lifelong benefit, if we can get her to kind of change some of those health behaviors or, engage in some of the resources that she has in her community, perhaps to improve her health a little bit. But if that's not successful, and for many of our patients, unfortunately, it won't be, the goals shift, right? Now we really should consider medication with her and say, in the long run, this is very likely to reduce your risk for cardiovascular disease. But our near-term goal is, let's make sure your blood pressure doesn't continue to increase, because That's the usual experience. Her blood pressure will only go up over time. As you said, that will increase her cumulative exposure to blood pressure and really enhance her risk. So we would miss an opportunity if we didn't treat her during this stage 1 hypertension phase to truly lower her risk as much as possible.
Yeah, I think one of the other things that's super helpful about having the risk estimate is to have these conversations to allow that quantitative risk to help communicate, well, you are at increased risk because we're getting this risk estimate, and move beyond qualitative considerations. No one wants to be told that their age is driving their risk, but it's included in the model with other risk factors that also contribute to that. And so I think it really helps as we start to say, well, this is why we want to start blood pressure medication today versus for the second patient. Well, let's see how 3 to 6 months goes, and then we can talk about it and give lifestyle a chance, even though we're going to recommend lifestyle modifications for both patients.
That's a great point. Everybody gets lifestyle modification. It's just, whether and when we need to start drug therapy. Yep, exactly right.
So I think that concludes our slide deck and discussion points for each section. So that concludes our last section. We've gone through the basics of why we assess risk, how risk is used in clinical practice guidelines, a deep dive of the development of the PREVENT equations, how we consider race and ethnicity in clinical practice, and review 2 cases where risk assessment really made a difference in how we counseled patients for antihypertensive drug therapy. So with that, thank you so much for joining the American Heart Association for this video on demand, and thank you to Dr. Heart.org to claim credit.